Shockwave Triad. He is diabetic, 60 years, alpha male. Those who understand alpha male, those who do not understand alpha male is very dominating, highly stressed. It came from the chimpanzee animal.
Somebody like Dr. Hazra.
Have 3-4 wives and do not want any others to invade. And he was that kind of personality. Hypertensive, non-smoker, giant diamond merchant. Past history of inferior MI and was treated by me in the same hospital, came with rest angina while taking a morning walk. And this time he presented with high troponin non-STEMI, KILIP 1, BP stable, GFR 60 ml, EF 45%. And so this is the radial route on argatroban, on cangrelor, and 6 French catheter, LED, and the circumflex. Now, circumflex doesn't look very critical on angiogram, but if you look carefully, there is something white structure, and which could be a thrombus, which could be a nodule in my mind. And obviously, these two arteries was initially target, but this picture, the first picture, actually post dilatation. So I'll be presenting some. More emphasis will be on the Shockwave rather than imaging. So I do use IVUS. So LED, there was some patchy calcifications, not a 360-degree calcium. And some point there was some small nodule in the LED, and the circumflex, there is a big nodule in the circumflex. And similarly, it was in the RCA, but that picture came only after having some dilatations of the right coronary artery. Initially, I have tried with your OCT catheter. I thought that will give a better picture for ISR in the right coronary artery stent, which I have placed a 3.5 millimeter DS in the past, about 4 years back. And next, this Gaia was introduced with a conventional technique, like you push a microcatheter with cyan blue, then you change with your Gaia catheter. Pre-DIL was done with a 2 millimeter simple balloon, then the IVUS Phillips 20 Hz. Now, those who are having a lot of inertia, inhibitions of doing IVUS in multi-vessel disease, I think the time taken to prepare the IVUS. If you take 20 Hz, it's a plug and play. You can do IVUS in 3-4 vessels, pre, post, within 5-10 minutes. So that's the beauty of having IVUS. And to learn IVUS, you should start with 45 Hz, HD IVUS, or Boston one. But to have the information around the stent diameter and simple cases where you are not interested in academic presentations, most of the doable cases can be done on 20 Hz, and they have other facilities like VH, and it can be done very quickly. So IVUS was done and did show some calcifications, and there was a concentric calcifications, almost I would say 340-degree calcium. Obviously, I was preparing for something which will reduce the slow flow on the reflow on the right coronary artery. Now, if you use rota, definitely it is a kind of contraindications. If you use a cutting balloon, it's a possibility. Again, there will be slow flow, no flow. But with 2 millimeter balloon, I could achieve some flow there. Now, I use sometimes the penumbra suctions in right coronary artery. So penumbra suction could not cross because there was a lot of obstruction at the calcium level at the stent mouth. So penumbra thrombosuction, there is Cheetah trial available. Cheetah trial is positive trial, unlike any other thrombosuction trial. So routinely I use, if you have a right coronary artery with huge thrombus. So I was using 3.5 millimeter IVL, and I have exhausted all the energy, like ET12 says, there only, and I could see ultimately good expansion. So you should know how the water behaves. If you know that the test of the water is good, the behavior of the balloon or expansion is good, now should be prepared to introduce a stent. So this stent was up to the ostia of the right coronary artery. Then there was some, I would say, under expansions, or there may be calcium outside the stent boundaries where you should use more energy, 3.5 millimeter IVL again, and that can expand. This is the only energy, as Dr. Ramesh Shamin was saying in the morning, the two energy which works beyond the stent strut, that is laser and the shock waves after stent deployment, which is not expanded properly. Now this high pressure balloon is also an option. The OCT was done, but that day I was not able to see any good images of the OCT. So I'm not showing that. Both the OCT images, pullback was very bad. Unfortunately, the machine, sometimes the luck doesn't favor you. Even if you give the good amount of saline and the contrast, maybe due to those software it was not working properly, not showing good images, or this clearance of that was not good. So distal RCA was, there are some lesions. This is not a very severe lesion, I would say. So rather than putting a metal jacket, I thought I'll give a drug-eluting balloon. You know, this coronary plaque sometimes like a simple pimple in your face, and if you just push these pimple back into the wall and you just give some medicines which is like a borocalendula for acne, these plaques are also healed. So these balloons, like a magic touch, it has improved, and there are newer drug-eluting balloon coming up, have a beautiful result. So proximal vessel, you put a stent, and the distal vessel, you do a hybrid with your drug-eluting balloon. Reasonable flow. Now my concentration was on the left side. Again, the OCT did not cross, maybe due to bend, or there may be some undue calcification over there. So these are the usual situation you face. The distal LED was again pre-dilated with 2.5 milliliter balloon. There was a distal disease, and this was treated with drug-eluting balloon. So distal disease is no point giving a stent 2 millimeter or 2.5 millimeter stent for Medtronic in the distal LED, though it is available. So proximal, the minimum stenting, minimal jacketing of the LED was my intentions. This proximal LED was dilated with 4 millimeter IVL balloon, and the circumflex nodule, as somebody was mentioning, Dr. Shavinson was mentioning on the nodule. I have a good experience of having used this IVL in almost 150 patients. Sometimes this nodule can be treated with full energy, like you have to use, sometimes you have to use 2 IVL balloons, so expensive. So all the energy was given in the circumflex nodule, and we could put a stent, but even then there was some under expansion. Then the LED was treated. There was some dissection because of maybe what sizing, but usually 1:1 sizing of the vessel is done with IVL balloon. And somebody may ask that the circumflex was not that tight. You did not do FFR or IFR. We have QFR in the system. The QFR was 0.85. So it was not less than 0.8. So QFR, because of placing a stent across the circumflex, anything happens in this nodule, the future intervention would be a problematic. And it was looking nasty, and maybe in acute coronary syndrome, this nodule can cause another event in the circumflex artery. So though it was not a critical one, I thought it is worth intervening this time because the future intervention would be problematic. So this is the flow, TIMI-3 flow we have achieved, and we can. So this is the cartoon, like this NASA at night in 2012 India, and 2016 when Honorable Prime Minister Narendra Modi announced electricity for all in 2014. And this is the UP. Anyway, one slide is missing. The UP on the left-hand side, there is not much of lighting, and on the other side, there's a lot of lighting in UP. So the country will be known whether it has progressed or not if you have more illumination of the country by electricity. Similarly, in the field of intervention, if you have imaging, OCT, etc., perhaps there will be a lot of glamour you can achieve in the field of intervention cardiology. When the OCT do not go, like if you have this kind of OCT, we have now ultra-fast OCT. This ultra-fast OCT can negotiate even a smaller, very critical lesions. This is presented in 2022 TCT, and this is 10 cc injections of the contrast, and I can image even less than 1 millimeter square of MLA, and it is a 100 millimeter pool, and it is a very small, very elegant catheter, very small, like 1.8 French, unlike 2.7 French. So ladies and gentlemen, in cardiology or any intervention, you have many choices, and sometimes the choices are very expensive. And sometimes, you have to pay a little bit of extra, like having luxury of 3 shockwaves in one patient, maybe first time in India. But some people can afford it, and they expect the best from the intervention cardiologist. Spending $2 extra on Coca-Cola bottle, some people can grab a Pepsi for the betterment. Thank you very much for your attention.
How many IVL shocks can be given with one?
Cost. What did you say?
How many shocks can be delivered with 8? So use the same balloon for both vessels.
No. There are three shockwaves balloon. One was 3.5, 3 in the circumflex,
So
and 4 in the LED.
3 devices.
Three balloons,
In the India shock registry, one of the largest IVL users is our alpha man from Calcutta.
3
So I
IVL
can
in
accept
same
he
patient.
using 3 IVL balloons. Only.
Balloons for the same patient.
I think what you said, in between was very good, and I think people didn't catch that. That's what I want to tell you. You had a nodule in the right side below the stent, which you treated with a drug-eluting balloon, and that's an important point because there is a type of nodule, the eruptive nodule, which does not have calcium all around, so it just sinks into the vessel wall, and you really don't require a stent. But
Yes.
how did you make that out without doing an OCT?
OCT did not go. OCT run was very bad, pathetic. I did try OCT in the right side, but as I shown, the OCT was not giving a good image.
Wonderful case, Dr. Hazra. But then on the left, on the LAD also, you have used a drug-eluting balloon. On the LAD also, in the absence of...
LED
Yeah, so is it your practice basically like, distal diffuse disease? You avoid even spot stenting and prefer a drug-coated balloon?
So there is a lot of paradigm shift in stent technology also. There are bioadaptive stents, there are stents without any polymer, and there are different types of drug-eluting balloon. So drug-eluting balloon concept came from Antonio Colombo, and he's also propagating the introduction of a concept where you have less metal, proximal metal, and distal or mid only drug-eluting balloon.
Yeah, but in the right coronary artery, generally it's like a conduit, right?
Yes.
See, because the diameter is essentially the same
Yes.
in the right coronary artery,
Right eye
proximally
is
and
3
distally.
millimeter.
Yeah.
3 millimeter, right?
Yeah, so it
And
probably makes sense in maybe a vessel like the LAD or the circumflex, but at the right, really, that argument, do you think
look,
it
the
works?
concept of DV versus D is completely different. You don't have to achieve 100% expansion or through diameter.
Not
You
that,
just-
see, because, you have a stent proximally.
Yeah.
You're not stenting the ostium. If you have a stent
I have stent
proximally...
to the ostium.
Okay, right. Okay. Thank you.